Hello and welcome to the Omega-3 Awareness Week. We have today a new session with Dr. Susan Carlson. She's Professor for Nutrition at the KU Medical Center in the University of Kansas. The subject, or what we're going to talk about, is one of the areas which I find most interesting in omega-3, that is the importance of sufficient DHA supply of the mother during pregnancy and breastfeeding. Susan, thank you very much for your time and thank you for participating.
You're welcome.
Let me just start off. You are one of the leading scientists, especially in this field of DHA, nutrition, pregnancy, breastfeeding. How and when did you actually get into this field, into this area of research?
It actually happened quite accidentally about 40 years ago, and I had a student who came into my lab, and I was interested in cardiovascular disease, and I was using the plasma from these infants who'd been fed formulas with high linoleic acid compared to what we called then a humanized formula. It didn't have long-chain fatty acids, but it had a higher amount of oleic acid like human milk does. And so I said, why don't you use the red blood cells? I'm sure these children who are getting the high linoleic acid are going to look very strange. As it happened, they were a little different, but the biggest difference was that we had a group that was fed mother's milk, human milk, and those babies had twice as much DHA in their red blood cell phospholipids. So as I started looking at what is DHA, why would anybody care? And I found this early work from Tom Clendenin that DHA doesn't accumulate in the brain until about the last trimester of pregnancy, and then over the next couple of years or so. We didn't know all of that then, but it was clear that it was an important nutrient during pregnancy. And at the same time, Martha Nuringer had published that monkeys, her rhesus monkeys who had low brain DHA, had altered cortical visual acuity, so meaning the brain was not getting enough DHA. And so I left cardiovascular nutrition immediately and started doing work with DHA, and I went to a preterm unit, a NICU, and I did work for the next 20 years or so looking at preterm infants' development. But after I came to Kansas City, I didn't have access to those babies, and I thought, why not study it in pregnancy? Because the baby's in there in that last intrauterine trimester, and maybe mom's health and intake has some role here. So that's how it all happened. But
and now I know this is a very broad question, but why is DHA intake so important for the mother during pregnancy?
Well, we've had a lot of theories along the way, and here's my short answer to that is I think it's important for probably a lot of reasons that we don't have solid evidence for yet. But the really solid evidence that we have now is that it reduces early preterm birth, which is a benefit to both the mother and the fetus, particularly the fetus, though. But I think there is some data saying it can reduce stress in the mother, which of course would be a good thing during pregnancy. The problem there is that we just don't have enough studies to really keep confirming some of these findings. I guess the bottom line is I believe there are benefits for the mother that we don't yet have solid evidence for.
So not only for the fetus and for the young child, but also for the mother during the pregnancy, there are benefits coming from the DHA.
Yes, that's my friend Kate Keenan, who works at the University of Chicago. This is one of the things that she is interested in studying. And also my friend, Dr. Kathleen Gustafson, who's got a paper really coming out on this. Really, she's writing it right now. So there is work coming out that I've seen, but it's not in the public domain yet.
Okay.
So I think my advice there would be stay tuned, because I think we're going to find that there are benefits for women to take more DHA.
Okay.
other than the preterm birth issue, which has become really a solid piece of evidence in the past few years.
So that was another question I had for you, and that is the DHA deficiency of the mother, is it clearly related to preterm birth? So is there scientific proof that these two are at least connected in a way?
I would say it's very solid now. So there was a Cochrane review, Maria Makrides in Australia and her colleagues published in November 2018 that showed that if women consumed omega-3s during pregnancy, and these were all supplementation trials, that they could reduce birth before 34 weeks by 42%. And that's huge. And preterm birth before 37 weeks by about 11%. So the thing that was interesting about that, though, is that the Cochrane review did not include any trials in the era where these supplements with DHA were being marketed to pregnant women in the Western countries. Mm-hmm. That changed somewhere between 2010, 2012. We began to get more and more prenatal supplements on the market with DHA. So at the time the Cochrane review was published, both Maria and her team and we here in Kansas City were doing trials to see if DHA could reduce birth before 34 weeks. Even though, it's important to note that even though these trials were in the Cochrane review, most of them were not designed to look at preterm birth. They were just studies where they gave DHA to women for various reasons. The thing that it turned out that it was actually quite valuable that we had these two trials going on in the era post-supplement availability, because in both of our trials, what we found is that women with low status had a significant reduction in early preterm birth if they took the supplement. And in both of our studies, that supplement was either 1,000 milligrams or 800 milligrams of DHA, so a pretty high dose of DHA.
Okay.
But the women who had a good status, and in our study, those were the women who were taking a DHA supplement already when we enrolled them. If you had good status, in our study, 200 milligrams had the same benefit as 1,000 milligrams.
Okay.
So I think that's pretty clear evidence that DHA can reduce early preterm birth, but that we also are having some women now who are taking the supplements and it's working. Right. That's what I would interpret. So you don't get as strong an effect if women are already taking DHA and have a good DHA status.
Right. And just for our visitors of the event, now preterm birth, what is actually the problem? If a baby comes too early, what is actually the consequence, or what can the consequences be?
Yes, the consequences can be as serious as death. And I've been talking with a friend who works at Johns Hopkins. She does studies of prematurity in the developing world. In the developing world, even being born before 37 weeks can be result in high infant mortality. In the United States, of course, and in most Western countries, we have neonatal intensive care units that do a very good job of keeping infants alive, even if they're born as early as 22, 23 weeks gestation. But here in the developing world, those early preterm births are particularly less than 34 weeks. If we talk about early preterm birth as less than 34 weeks, those babies stay in the hospital longer, they get more clinical problems, and they have a higher risk of cognitive loss and other developmental delays that can occur.
Okay. Now, I have read somewhere, and actually was also involved once in a little study where we analyzed the fatty acid composition of mother milk in different countries, And we saw that mother milk very often has a ratio of DHA to EPA of around 4:1, roughly. Now, that means that EPA also seems to have some kind of use for the child. Usually you only hear DHA is important during pregnancy. Do you know of any reason why EPA should also be important, or is it just coincidence?
I think I would have to say there just aren't studies to actually address that question. If you think about it, though, the ratio of DHA to EPA in human milk is probably to some degree related to what the food the woman is eating. For example, if she's eating a higher seafood diet, she might have a higher ratio than 4:1. But if she's just getting, we do know that synthesis from alpha-linolenic acid to EPA works reasonably well, but from EPA to DHA, that's really the problem. And that's why the studies have been giving preformed DHA, because there's no study and there have been a lot of studies done. No study that's shown that you can give EPA and get DHA levels that are in the range where you can get these benefits that I'm talking about.
Right.
So I think it's an open question. EPA could be having a role in vascular function or some other things. There's nothing to say that it's a bad fatty acid, but we don't have the evidence to say it's a good one.
Right. Now, another question which often I hear is, in the Western world, we have a kind of a oversupply of food. So do we really have a deficiency in DHA in our diets? How do you see that?
Well, so I'm trained as a nutritionist, and when we use the word deficiency, we don't throw it around lightly, but I would say low intake. Do we have evidence that women have low intake of DHA and low status because they have low intake? And the answer to that question is absolutely. And if you are not an eater of seafood, you most likely have an intake less than 150 milligrams of DHA per day on average. And the paper that I'm just getting ready to submit after we get off this call, we showed that women in our trial, there were 1,310 women included. If they consumed less than 150 milligrams per day, they had a dramatic reduction in early preterm birth and preterm birth if they took a high dose of DHA during pregnancy.
Okay.
So I think 150 milligrams per day is kind of the sweet spot. The truth is, though, that 59% of these 1,310 women, so almost 60% of them, had an intake less than 150 milligrams. And we're now doing this, we're now looking at this it's standard of care in our OB-GYN clinics now, to ask women to fill out a survey. And if they're consuming less than 150 milligrams, they get a message that they need to have a higher dose of DHA.
Okay. And
if they want to reduce their risk of preterm birth.
What dose would you recommend? 200, 250 milligram, 1,000 milligram? What would you say is sufficient during that time, during the pregnancy and breastfeeding?
Well, the evidence right now is that the evidence is that if you're low, and this is just new evidence from the last studies that I talked about, the ORB trial in Australia and our ADORE trial here in the United States, that evidence is that you probably need 800 or 1,000 or certainly more than 200 milligrams if you want to reduce your risk of early preterm birth, if you're a low consumer.
If you're low, and if you started off low already.
Right. But the beauty of it is that if you started out above 150, 200 milligrams was equally effective.
Okay.
So I guess it raises the question, which we don't have an answer to yet, is if you when can we get women's status up that it would be beneficial, that maybe they could get by with a low dose if they started earlier? We don't know the answer to that question. And the reason we don't is, of course, we need studies, but when we looked at low consumers, they also are more likely to be African American. They have lower food intake. They have lower supplement intake. They have a lot of factors that have been associated with preterm birth. So some of these women who are low consumers may need a higher dose, even if they started earlier. Right. That would have to be another study, because women who are low consumers are different from women who are good consumers of DHA. Right. There's education differences as well. If you're an educated person, you know that DHA is important in pregnancy. That information is out there, and you may have started taking a supplement when you became pregnant.
Right. Well, the thing is, it almost answers my question I have over here, where I said it's only during the last 3 months of pregnancy and the first, let's say, 2 years, where the DHA is really necessary for the construction of the brain and the eyes and the nerves of the young born. But you should actually make sure probably that you have already a sufficient high DHA level when you go into pregnancy, and not only start taking the DHA in the last, let's say, 3 months of your pregnancy, right?
Yes. There's good evidence that the DHA status of the mother, remember, DHA can be stored in women's adipose tissue. So coming into pregnancy with a good DHA status, because you're a seafood consumer, or you want to get pregnant and you started taking a DHA supplement, it certainly is a worthwhile thing to consider doing, even though we don't have studies that prove this. What can it hurt, right? It can only help.
Right. Now, this is a question, a personal question I have ready. If you have a young woman, which, let's say, has an undersupply in DHA during pregnancy, and then later on, can you correct this undersupply in DHA by a DHA-enriched baby food formula? So would that kind of make up again for the deficiency the mother had, or the undersupply? Can we correct that status?
It depends on what outcome you're interested in. For many years, our interest in preterm birth is actually kind of accidental. For most of my career, I've been interested in the effect of DHA on cognition. And I've teamed up with a really wonderful team here in Kansas City, Dr. John Colombo, who's a cognitive psychologist, and electrophysiologist like Dr. Kathleen Gustafson. So we have a team of people who are actually interested in the development of the infant. Mm-hmm. And one of the first studies we did was funded by Mead Johnson Nutrition. We started it in 2002 before DHA had been added to infant formula in the United States. So we had a control group who were just receiving the standard formulas at that time. And then we had 3 groups that got basically 3 different levels of DHA. In that trial, we followed those children out, some of them to 9 years of age. We found cognitive differences out to age 6, and we found differences in brain function and structure out to age 9 in about half of them that we followed that long.
Okay.
Then we decided, well, maybe we should also look at cognitive function of babies whose mothers got DHA. So we did a trial called the Kudos trial, and we began that in 2006. We followed those children out to age 6. We didn't find any cognitive benefits of the supplementation of the mom. And this has actually been shown in a couple of other trials that were done to look at cognition by giving moms DHA during pregnancy. But the caveat here is that all of these trials in pregnancy supplementation to look at infant or child cognition were done in the era where DHA had already been added to infant formulas in the West. So I think that's a complicating factor. I would say right now that you can make up for inadequate DHA during pregnancy if you provide DHA postnatally, if you're talking about cognition.
Okay.
But maybe the effects on cognition of in an era where you're getting it postnatally doesn't matter. There are some differences. We have published this. There are some electrophysiologic differences in how the brain connectivity looks, but it doesn't show up on cognitive tests. I have the bias that you build a better brain if you give it during pregnancy and postnatally as well.
Okay. So from the brain structure, you can see an improvement, but not necessarily on the function. Is that correct, the way I understand it?
Yeah, when the brain connectivity, it's the function, yeah. Not its structure, but its function. It's functioning differently. The way the brain is functioning when you do something like a test where the child has to inhibit a response.
Right.
Their brain is doing different. It's connecting differently.
Okay.
And we have that. The beauty of our studies is that we have that data on the cohort whose mothers didn't take DHA. Remember, this was pre-DHA availability, so their mothers were not getting a supplement. And then we have that data on babies whose mothers got the supplement, and the baby got a supplement. So you see gradations of connectivity that look better and better. And the best were the ones whose mothers got DHA during pregnancy, and they got it postnatally. Okay. But again, no effect we couldn't find an effect on cognition.
Right.
We found it on things like in the ability to inhibit, which is a cognitive function. But not an IQ kind of function. It's
right. Now, I heard at some place that with every pregnancy, for every child, the DHA status of the mother normally decreases. Does that mean, in the consequence, that my older sister is more intelligent than me? I mean, that the both siblings you have, that the oldest one or the first ones have a better brain, a bigger brain, a better functioning brain?
Well, my husband is a genius, and he was the last of 7, so I don't think so. I don't think that can be extrapolated.
Oh, that's good.
There is some evidence that there's, from a study done in the Netherlands some years ago, that human milk levels decrease if a woman has closely spaced pregnancies she's on a low DHA diet. And that's probably true. That more DHA is coming to the earlier births.
Right. Now let's just switch for a moment to the population which is strictly vegan. Does a strict vegan diet have an influence, a negative influence on the brain development and cognitive development of a newborn?
There are not any studies of vegan cognitive development that I'm aware of. I think it would be rather hard to do that. You'd have to have quite a large number of vegans who had pregnancies. I think the way I would address that is that, and you commented on this in your questions, that there are vegetarian sources of DHA.
Right.
And I gave a talk a few years ago at Loma Linda, which is, as you know, a vegetarian-based cohort there. And this is what I said, that you don't need to, I think it would be wise for them to take a DHA supplement, and there are vegetarian sources that are available for vegans.
Is there any proof that vegan cultures actually can convert alpha-linolenic acid more efficiently into DHA than other people? Because if I look at strictly vegan, I don't know, in populations like in India, they're living like that over generations, right? So they must be able to convert the ALA into DHA.
Well, I wish I had an answer to that, because many years ago I gave a lot of talks on DHA and development, and I think every time I gave my talk, someone would ask me this question. So I have an interest in knowing the answer as well. I will say there are genetic differences in populations, racial differences that have been noted in ability to convert alpha-linolenic acid to DHA, but I'm not aware of any study in populations that are traditionally vegan. I think it's important to remember, though, that I don't think that even vegetarians in India avoid eggs or things like that. Eggs can be a very good source of DHA, particularly if they're sort of allowed to roam around freely and eat vegetation that's in the environment.
Right. That's correct.
So I wouldn't say that I know there are people right now studying DHA supplementation and preterm birth in India. What they will find will be interesting.
Right.
And there's also evidence that pregnant women in India have a rather poor DHA status. So it's possible that, and certainly their blood levels of these nutrients are low. So it wouldn't suggest that they're making DHA really well to me.
Okay. But in any case, there is a, let's say, vegan source. The algae oil DHA is available, and it's chemically, it's exactly the same as the fish DHA. So nobody needs to be, let's say, deficient in that sense, right? Because it is available.
That's correct.
Now, recently, I think you published a paper with your team where you developed 7 questions to find out if a person has a lack of DHA in his diet or not, or a woman has a lack of DHA in her diet. Can you explain us a little bit, or I'm not sure, was it DHA or omega-3 status in general? But could you explain that a little bit?
Yes. So we did a multi-site randomized clinical trial asking, is 1,000 milligrams of DHA superior to 200 milligrams of DHA to reduce birth before 34 weeks?
Okay, yeah.
And what we found, and I mentioned this earlier, is that if women were having a low blood level of DHA, they benefited with it, reduced their rate by half. But if they had a high blood level, there was no benefit of 1,000 over 200. One of the nice things in the 2 trials we did here in Kansas City, there was another trial called Panda that enrolled 300 women, and we harmonized our methods. So we have the same data on all these women. And one of the things we did was we asked the women at the beginning, using these 7 questions, what was their DHA intake? And it's based on a Connie Karatko published this a number of years ago. It's asking questions about 3 different categories of fish that have either high DHA, modest DHA, or low DHA. And how much liver do you eat? How many egg yolks do you eat? What else? The other, what is your intake for? Chicken. How much chicken? Because chicken has some. And then also, do you take any supplements with DHA? How much DHA is in it? How often do you take them? We had administered that questionnaire to all 1,400 women, and we have good birth data on 1,310 of those. So why not look at whether intake makes a difference? So the randomized trial, you have to publish what you said you're going to do, and that's based on the blood level. But we started thinking about this practically. If you're an obstetrician, you read our paper, you go, where am I going to get a blood level on this woman? Which blood level should I use? How do I interpret that? Then wouldn't it be a lot easier if you could just use the 7 questions?
Right.
and know the intake. So that's the paper that I'm getting ready to submit today,
Okay.
which basically showed that if you were consuming less than 150 milligrams, getting the high dose reduced your level of early preterm birth to the same level as women who were getting more.
Right. Right.
Women were getting more at the beginning. If they were getting more than 150 milligrams at the beginning, they also had a low rate of early preterm birth.
Right. Right.
So I mentioned earlier that women who have a low intake in our study did have different maternal characteristics, but the beauty of it is if they got the high dose, it didn't matter that they had these high risk factors for preterm birth because it worked for them.
Okay. Okay.
And we've already, it's now standard of care in our clinic to ask women these questions. And when they complete it, a message goes to their caregiver saying, this woman should keep up her good intake of DHA, or she should take more DHA.
Okay. Well, that's a very good idea, because I think that's also one of my last question actually I have for you. I'm not sure in the US, but at least here in Europe, and especially I would say in Germany, do you think are there still so many physicians which still, in spite of all the evidence we have gathered over the years, but still do not really actively recommend the supplementation or the intake of a DHA-rich diet during pregnancy? That's something which I find really very hard to understand. What is your experience?
My experience has been very gratifying. The thing I would say is physicians pay attention to data, and the data is pretty new here around preterm birth. So I think when there's evidence, practice changes. And what's been limiting up till now is when it comes to like improving the intake and the diet, it all sounds very nebulous to physicians because, why? What's the benefit here? Show me the study that the cognition was higher and these kids had higher IQ or whatever is the outcome. The thing that I found really gratifying is that obstetricians understand preterm birth. It's not like IQ where you can wave your hands around and say, well, these people don't really understand what they're doing, or we just don't understand how the brain works. But numbers like this child had a gestation of 33 weeks. Those are recorded right in the medical record. Right, and you can see it. And you say, if you just do this, you can reduce preterm birth. I don't know where this is all going to go, how quickly practice will change, but it's gratifying to me that as soon as I showed this data to our OB, even before the paper's published, they said, we're making this standard of care.
It's wonderful.
It's so easy. It's so easy to ask these questions. And
right.
It's pretty hard to go get the blood measure.
Right.
It's not
easy. Right. Oh, that's wonderful. And I hope things will change also in that sense, because it is relatively easy to get this under control. Right. So, well, Susan, thank you very much. Our time is up. It was wonderful talking to you. And I think you gave us a lot of good information. I wish you a lot of success, though, with your studies over there. And from our side, as you know, we would like to get this Omega-3 Awareness Week. It's really directed more towards the health professionals and the doctors in order to give them some more information, basic information, which might then trigger a little bit of interest where they can then dig more into detail and understand better the benefits of Omega-3. Anyways, thank you very much for participating.
You're welcome. I will say one more thing. Yes. In the paper, we've put the Red Cap survey. Anyone could take this and utilize it in any clinic in the country, whether it's a OB clinic or any kind of clinic
Okay.
to identify people who are low consumers and should probably increase their intake.
Wonderful.
So,
and when is this going to be published? You know that?
well, I'm just submitting it, and
It takes its
vagaries
time.
of publication these days. Yes. Hopefully, we'll get it published within the next few months.
Yes, yes. Okay, Susan. Well, thank you very much once again, and we'll stay in touch.
And enjoy Spain. I'm jealous.
Yep.